Well, we are so excited to be with you this morning. And if you haven't introduced yourself and told us where you're from, go ahead and do that over in the chat. My name is Jennifer Street, and I am presenting today with my colleague, Kelly. And she's coming to us from Florida. So we want to tell you a little bit about us, and then we want to hear from you. So I'm coming to you from the Houston area, and I have been in Houston for a little over 4 years. And you see my little ones there. That was last Easter. They decided they needed to stick their tongue out in every single picture. So if you got to know me a little bit more, you might see things like I love the Appalachian Trail. I'm headed up there in May. I do a lot of music, ride a little recumbent road bike, and therapeutically, some of the techniques that I'm trained in are accelerated resolution therapy, heart math, Gottman couples therapy, and EGALA equine assisted psychotherapy. So I'm going to pass it over to Kelly and let her introduce herself.
Thank you, Jennifer. My name is Kelly Buston. Some of you may know me. I was just recently married, so I was previously Kelly Breeding. So if you've emailed with me before, you've seen that my email is a little bit different. I'm an LCSW. I'm also the executive director of an organization called ART International, where I oversee all the policies and procedures and strategic and operational responsibilities for ART International. We are working towards a lot of expansion and execution of our mission. Jen, if you want to go to the next slide, please. Thanks. This is a little bit about my life. Like Jennifer said, I live in Tampa, Florida. And I live in a house full of boys, as you can see, 2 male dogs, 2 young children, and my husband. And we, spent a lot of time together last year. Obviously this whole presentation is about working through telehealth. So I experienced a lot, with my kids last year doing virtual learning, and definitely understand the importance of doing things correctly over a virtual platform. So it's really important to us. And I think on the next slide, we would love for you guys to post your name in the chat, and then one thing that you're hoping to learn from this session today.
And while those are coming in, I'll tell on myself. The way we actually got invited to do this was I had prepared this presentation for the NASW conference in Texas that's coming up at the end of the year. And during the ice storm, I forgot to turn it in. So I wasn't going to be able to be included, but the topic was something we were wanting to cover in the webinar series. So here we are. And I see some familiar faces that we met at the last time that NASW Texas was in Galveston. So welcome to those that we have met before. I love these coming in, working with emotions on telehealth. Kelly, you want to field a few of those?
Sure. So we've got best practices in working with youth, honing some skills that they've already developed in working through telehealth. Let's see, someone with a brand new, my thing is brand new baby, so waiting for license and love to know more about telehealth. Wants to learn the road to present. Lots of different, starting a private practice, looking for continued education and doing teletherapy, working on emotions in telehealth. These are coming in fast, sorry. Best practices, tech intelligence, which is something I haven't heard before. Addressing possible substance abuse issues when you've never met the client in person, which is definitely, it can be a daunting task when you're just over, getting into the telehealth space. Learn more about ART in telehealth. Jen, did you see any other ones that you?
No, that looks good. And I really like this idea of technological intelligence. We have IQ and EQ, so now we have TQ, I guess. All right. Well, thanks, everybody. I Can't promise that we're going to cover everything listed there, but we're going to touch on probably 90% of what you've put in the chat that you're interested in. And feel free to chat in questions as we go along. Taylor has graciously agreed to keep a list of those and consolidate them for us. And we have set aside some time towards the end to make sure that we address those for you. So let's jump in. At the end of today, our hope is that you're going to be able to recognize the core tenets of effective trauma-informed care, be able to list the 5 essential processes of trauma therapy, define the components of Hipaa compliant telehealth, establish appropriate safety considerations when using telehealth with trauma, identify gaps in knowledge to the ethical treatment of trauma via telehealth, learn how ART and other trauma-focused techniques can be utilized on telehealth, and then experience a little bit about how eye movements can actually be used in therapy. So we can do all that in 90 minutes, right? We better get to it then. So I'm going to let Kelly start us out talking a little bit about the essential components of effective trauma therapy.
Thanks, Jen. So over the next couple slides, Jen and I are really going to introduce the structure, like she said, the structure of essential trauma therapy. This first slide definitely talks about trauma-focused psychotherapy, where, for mental health professionals, I just lost my screen. Sorry about that. Mental health, the most important clinical strategy supported by strong evidence is to have a firm understanding of the core components of effective trauma-focused psychotherapy and to deliver these in a patient-centered manner that fosters continued treatment engagement, which is the most important variable in predicting treatment effectiveness.
And so that first I'm sorry, Kelly.
Nope, go ahead.
That first component there is the therapeutic relationship, right? And so in order to invite people to narrate the traumatic event, whether that's through written word, spoken word, visualization, exposure, is that we have to facilitate that process. And I think a lot of times we get very nervous about not knowing the right technique or having all of the right trainings. But if we go back to Lambert's factors of the plan change process in therapy, remember that 40% of the things that impact change in therapy are client factors completely outside of the session, right? And the counseling relationship accounts for 30%. So one of the main takeaways today is that we have to work extra hard in telehealth to create the same type of therapeutic alliance that would come more naturally in the office setting. So we're going to give you some tips on how to do that, but only 15% of the change process is actually attributed to your counseling method or model or theory. So don't ever underestimate the value of your presence and the importance of the therapeutic relationship. Like a broadcast. Back to you, Kelly.
Thanks, Jen. So one of the first components that, to piggyback on what Jet was just talking about is cognitive restructuring, right? So trauma changes our views of ourselves, the world, our spirituality, basically everything in our lives. So with cognitive restructuring, it involves gaining a different perspective on the traumatic events and one's responses. For an example, we have up here is coming to terms with guilt, self-blame, pervasive mistrust. And this often emerges naturally during the narrative process.
And our next component is in vivo exposure. And if you've heard of prolonged exposure or other types like narrative exposure therapy, one of the things that we do in trauma therapy is expose ourselves to the stimuli that's causing distress in hopes that eventually there will be a desensitization. So when we say in vivo, that term actually means in the living. So an in vivo exposure would be, for example, if you have a fear of dogs and you go out and you walk a dog, or you do that in the presence of a therapist, that is in the living exposure. And then in vitro exposure is in glass or in a test tube. So this would be experiencing that distressing stimulus in a more controlled environment, safe environment. And then we have imaginal exposure, which is a type of in vitro exposure, but it's done through visualization and imagining the stimuli that causes distress versus actually going and touching it or interacting with it. And this process, as we talked at the end about accelerated resolution, you'll see how all of these components are present in the ART protocol. And exposure is required for desensitization. And that's about all we'll say about that now, but just know that the goal of exposure is habituation. Eventually, over time, that our distressing response will clear itself up the more we experience desensitization.
Another component that is another big piece of accelerated resolution, which we'll talk on later, is the use of relaxation exercises. And, these exercises are aimed at addressing physiological reactivity that can include diaphragmatic breathing, progressive muscle relaxation, mindfulness, eye movements, and other various approaches, including simply bringing greater awareness to the level of distress that's happening in somebody's body through a routine use of subjective distress measures. So I wanted to utilize the chat on this one to ask, like, the group that's watching, what are some of your favorite relaxation exercises that you use with your clients? And I'll go ahead and open this and read. Visualization is one. Creative arts. Conscious breathing, box breathing, progressive muscle relaxation, tapping into the 5 senses, grounding and breathing, breathing in PMR, meditation and belly breathing. So lots of really good relaxation exercises. Jen, was there anything you wanted to add on talking about relaxation on top of that, as far as like how,
Sure. Well, I think one of the keys here is that trauma work is hard, and we do a lot of things to avoid pain and avoid hard, right? We like convenience. We like to take a pill instead of do something hard or feel pain. So when we neglect to include relaxation as part of the trauma therapy experience, the client will develop an aversion to wanting to do that work. And that's what we're trying to avoid, and why the relaxation component is so important. And in a few minutes, when we talk a little bit about the development of trauma therapy over time, we'll notice that that's what all the great minds were saying. Yes, we have to desensitize, but that's hard. So if we add some relaxation into that process, maybe we can make it easier and less re-traumatizing. So that's why it's so important. And that goes right along with the last step, which is the psychoeducation. Understanding the underlying mechanisms that cause trauma and knowing what trauma is doing to the nervous system and the body is a really important piece of treating trauma, whether you're on telehealth or in person. So I like to use the analogy of a pool. It's very brave to think that I'm going to climb up the high dive and jump into the deep end and just deal with all my trauma. I'm tired of it. I'm going to jump in and do it. But we know as therapists that that's counterproductive. That would be akin to jumping in the deep end and you don't know how to swim. So the visualization, or the metaphor I like to use, is the idea of wading into one of those pools that gradually gets deeper. So your job as the therapist is to help people walk into that water and feel comfortable as it gets deeper. When they feel like they're a little too deep and they can't tread water, you back up a little bit. And eventually we're treading water in the deep end. So that's really a more helpful approach. And I always talk to my clients about creating a foundation of safety and self-care that's required to do this work. But what we know about treating trauma is that when we do that, all the other associated comorbidities are affected. So sleep improves, substance use goes down, relational problems go down. less difficulty with mood regulation. Clients are less at risk for long-term health consequences from untreated trauma, and their risk for other mental health issues goes way down. So treating the trauma is very important to ensuring their long-term physical and emotional health. So the question is, how do we do it? You guys are all like, yeah, we know, we do all this stuff, but how do we do it? And I'm not very good at jokes, but my joke here is very carefully, right? And we all know our ethical responsibility to do no harm. And that's why we're all here, because we want to know, how can I do this in a way that keeps me safe, keeps the client safe, is ethical in practice, but also works. So that's what we're going to talk about. Back to you, Kelly.
Thanks. So now we're going to talk about trauma-informed care. As social workers, which I'm assuming everybody on here is a social worker, or at least in the mental health field, we know that as an individual, a client is more likely than not to have a history of trauma or an occurrence of a traumatic event in their lives. So the idea of trauma-informed care is that we approach our work and our clients by recognizing this presence of trauma-based symptoms and acknowledging the role that trauma can play in someone's life. And so Jen's created this this visual component here where it shows kind of the importance in the road to trauma-informed care. I wanted to share an example of how important something like a trauma-informed care environment can be. I work with an organization here in Tampa, Florida called Metropolitan Ministries. It's a very, very large organization that serves individuals who are at risk of or have become homeless. And we went in and we trained all of their mental health professionals in accelerated resolution therapy. And while I was going through that process, I learned that they had developed this program that, basically the entire staff, everybody involved in this organization, and they have a staff of hundreds of people, from the executives all the way down to the janitorial staff. They have all been trained in trauma-informed care. And the idea is that trauma and chronic stress, especially, within their population that they're serving, does have a deep and lasting impact on humans and the families and the communities at large. And so they've really developed this mantra of, rather than approaching people with the idea of what is wrong with you, to what happened to you in your life, and how can we work towards providing you the tools to overcome those things. And the six key principles, I went back and reviewed a lot of my notes that they really work off in this trauma-informed care setting, is that they create a space of safety. They approach everybody with trust and transparency. They utilize a very strong network of peer support. Like I said, all of the staff, anybody who comes in contact with a client, no matter what the context of that client, that contact is that they are all fully aware of the situation that these individuals are experiencing. A lot of collaboration and mutuality. So meeting people where they're at, and then is approaching them from a place of empowerment, and voice and choice, which is a word that some of the words that they use. And then the sixth one is to understand the cultural, historical, and gender issues that may be presented in this population. It was really amazing for me to go in to see something put together like that, and to see it in work with all of the individuals that are involved in this organization. And it's been extremely successful. They're in the fact that they're treating these individuals and they're breaking the cycle that a lot of these individuals are experiencing. So Jen, if you want to go to the next slide. So this one is about re-traumatization. So Jen had mentioned earlier that the foundation of our jobs obviously is to do no harm. And so how does that translate to telehealth? Some of the things that we're going to cover in the following slides when we move to start talking specifically about telehealth is, creating a safe space for people. So this goes back to the 6 principles that I had mentioned earlier: creating a safe space, securing confidentiality, making sure that it's a secure, confidential space for this person, having a safety plan in place, which could be, the utilization of a support person. And then one of the questions that I wanted to ask that for everybody to consider, and you can utilize the chat as we move into the next slides, is how might we traumatize somebody through a telehealth platform? And let's see what some of these answers are. Oh, maybe that's why everybody, oh, here we go. The lack of listening and empathy, becoming distracted, not assuring that your environment is uninterrupted, paperwork requirements, ignoring nonverbal cues, not looking presentable on the screen, being late, rescheduling, having it be impersonal, the therapist hiding behind the screen, internet issues and losing the call. These are all wonderful things that we're going to talk about. Living out of the country where the internet is not always dependable, eye contact issues. Let's see. All right, Jen, do you want to?
Oh, these are great.
Yeah.
And some of them are barriers that we don't necessarily have in person. And I will tell you, one of the things that I actually did as a result of doing so much telehealth was I got LASIK. I wanted to do it anyway, but the distraction of the glare, right, and not being able to adjust for it, and just personally being on the screen so much, but I found a real difference, because if something would pop in on my screen, even if I wasn't paying attention to it, my clients could see it. I remember I was in a session one day and my sister sent me a whole bunch of shared pictures, and I didn't open them, but they were all like showing up on the corner of the screen, and my client could see them flashing in my glasses. So really thinking about that, how do we demonstrate that we are fully present in that moment in this setting is really very, very important. And then also thinking about Kelly was talking about the components. So safety, choice, collaboration, empowerment. And in practice, we do these things by making sure our waiting room is private and welcoming, by providing a clear message about people's rights and responsibilities. They get a patient handout that says what their rights and responsibilities are. They're involved in the planning and evaluating process. And of course, we keep healthy boundaries and provide an environment where they feel affirmed. And all of those things that everybody just listed, I had actually had a few sessions with someone on telehealth, and I discontinued because of how distracted she consistently was, with no acknowledgement. And I thought, that doesn't make me feel, and so it was interesting to be on the other side and feel like I don't feel very heard, or like I'm the most important thing in the room right now, even though we're not in the same physical space. So even thinking about your waiting room, if I am, we run behind on telehealth sometimes, just like we do in the office. We try not to, but sometimes it's unavoidable. So utilizing a platform that allows you to have a waiting room where you can welcome people when they enter the waiting room. They know that you see them. If you're running a few minutes behind, you're able to say, I'm running a few minutes behind, I'll be right with you. Just so that people feel seen and heard, right? And we also can use EHRs for pre-session paperwork and consent. If you're not familiar with those, things like Simple Practice, I think we've all heard of that one. But that creates a very user-friendly and very organized way to get the client into care. So doing the things you would normally do before they come into session or when they're sitting in the waiting room. And we do sometimes have to work a little bit harder. One of the barriers mentioned was ignoring nonverbals. But what about the nonverbals that you can't see? Right? So being really cognizant, if you're doing a grounding exercise, I can't see that my client's feet are on the ground. So I need to make sure that I remind them to put their feet on the ground. If they're bouncing their leg, I could be bouncing my leg right now and you wouldn't know, right? So some of those mental status exam checks, we have to work a little harder on by asking verbal questions because we can't observe the full body. And also boundaries like location and privacy and not being in motion. I have clients that have done telehealth in their car, and I don't have a problem with it as long as I know where they are and their car is stopped, right? Because that might be the only private location that they have. So usually they're in the driveway of their house, but that's, you know, something to consider. I've heard stories of people having clients show up without a shirt on. I mean, a male client showing up without a shirt on. And, you know, just the same boundaries, even more so, that we would have in session, we want to have there. All right, so again, I told you I'm not that great at jokes, but how do we do this safely over the internet? Again, very, very carefully. So we have a little poll for you.
So we want to, we're going to ask about some questions on the poll about what are your greatest concerns about engaging in trauma therapy via a telehealth platform?
Poll should be launched and y'all should be able to see it on your screen. All right, looks like we've got results coming in. I'm gonna give it a little bit and then I will share them with y'all.
And we fully realize that we didn't cover every potential concern. So if you have a concern that's not listed, please feel free to chat it in.
Somebody just said they'll leave the process of healing prematurely.
Looks like almost everybody's answer. Nothing else coming in, so I'm gonna end the polling. All right. So it looks like the majority of people are more concerned about that the treatment will not be as effective.
There was another chat in about the client being re-traumatized as well.
And these are all extremely valid concerns. Yeah, the client becoming emotionally dysregulated, for sure. Let's have a, in the chat, this is not a poll, but how many people are actively doing telehealth? If you want to give us a thumbs up or a thumbs down, or raise your hand if you're currently doing it. I started telehealth in 2012 when there weren't any rules about it yet. And I did it because I was moving across the state and I thought I might have 4 or 5 clients that would like to stay with me that would be appropriate to have virtual care, relationship issues, some ongoing support, you know, not my suicidal teenagers. So I transitioned a lot of my clients to local care, and then turned out that I had about 15 clients who transitioned with me to telehealth, and I couldn't find guidelines anywhere. Nobody was saying, how do you do this thing? There weren't any HIPAA laws about it yet. So I was on my own and I was making it up as I went. And then I was encouraged to see as laws started to be published that I was already kind of right on track. The only thing I wasn't doing in the early days was there weren't HIPAA secure video platforms. So I didn't have that at first. But those are very, very valid concerns. And when the concern that a client would leave the screen and hurt themselves is extremely valid, but also the same concern that a client would leave your office and hurt themselves. So I think 10 years ago, everybody was scared to even think about doing counseling or even medical care on a computer. And now it is a primary mode of service delivery. So would you rather a client have the very best telehealth that we can offer them or have no service at all? I think sometimes we have to think in that manner, right? Kelly, you want to say anything else about that?
No, I agree.
So let's talk about some of those considerations to help balance these concerns. So first off, you are going to have to choose a platform if you're not already doing telehealth. And there are plenty of platforms out there. We don't advocate for a particular one, but some of them are, Doxy is secure, has a free version and a paid version. Zoom for healthcare, which is more expensive than just your regular Zoom room, but it has the components that you need for security. And then you can even get your platform integrated into your electronic health record if you're using Simple Practice or Care Paths. Somebody's saying that Therapy Notes does that as well. So that's a one-stop shop for having your notes and your intake paperwork and your billing and your scheduling and your video platform all together. And I will say that personally, I prefer video over phone. I feel like it's easy to get distracted doing a virtual health over phone versus at least being able to have some face-to-face contact. You also need to consider your Hipaa compliance. So any companies that you're using to provide services, any place that you're storing protected health information, and you all know this, you need a business associate agreement, even payment information. There are a whole nother set of laws about how you have to securely store credit card information. So making sure that you have consent to store that you're storing it in a secure platform. And then also setting up your space. Believe it or not, clients get very attached even to your virtual space. If I move from here to my chair, which used to be in my physical therapy office, even then people look like, oh, you're somewhere different today, right? So if you do a really good job of protecting your space, just like you would in your office, clients get attached to it. So I have set my work from home space, which never has a client in it, in the similar way that I would set up my therapy office. And if I'm going to be away from that location, I let clients know where I am and that there's nobody in the room with me, right? Now, typically I wear headphones. I'm not today because in this presentation we're sharing some videos and things, but even, using headphones to ensure that nobody else in my environment can hear what they're saying. I have a white noise machine outside my door, which sometimes is not great enough to keep you from hearing my kids screaming like a minute ago, which I'm so sorry for. They're having fun with dad. But then, so setting up your space, being consistent in your delivery, letting the clients know that they have full privacy, and then being skilled, having that technological intelligence that was mentioned earlier about how to navigate the tech issues. So some of the most common tech issues are you can't hear the client, you can't see the client, or there's such a significant delay in the bandwidth. So one of the things that I do with clients is make sure they always have the call-in number as well, and I have their phone number. So if I am losing part of their narrative because the internet is slow, I'll say, you know what, let's go ahead and mute our audio on our computers, and I'm going to call you that way. Even if the video lags, I don't miss what you're saying, right? Because when I have to re-ask the client what they just said, it damages our rapport. Because it's not that I'm not listening, it's just the technology is not facilitating the active listening like I need it to. So those are some options for navigating those tech issues. And we are going to talk about administering eye movement. So some of you I noticed put in EMDR, safe place visualization as one of your relaxations. And there is significant concern about how do we administer eye movement therapy safely over telehealth. I have seen a lot of things advertised. I've seen self-directed EMDR advertised, which scares the bejesus out of me. I don't know if that's an appropriate word to use, but that's what came to my head. Because EMDR and accelerated resolution therapy and even prolonged exposure are such powerful therapeutic tools. And someone mentioned a concern earlier about a client having a strong reaction on telehealth, right? That is a lot more likely to happen in one of those eye movement based trauma therapies than in traditional CBT talk therapy. So it's really important to know how to do that. And we're actually going to, Kelly and I have a demo where we're going to show you part of a telehealth session with eye movements. Also, we need informed consent, which I'm gonna leave for Kelly to talk a little more about. And we want to screen the clients for the appropriateness of the modality. Whatever the modality is, we want to know that it's appropriate for them. So not only do they meet the criteria they would have to meet to get this therapy in person, but they also meet the additional considerations like, do they have privacy? Are they living in a home where there's domestic violence and anything they say in telehealth might cause a safety issue to them, right? Is there someone who's going to overhear what they're working on therapeutically? And that involves creating a telehealth safety plan. We're going to show you an example of that as well, and having a support person. So I am extremely adamant when I feel someone is appropriate and ready to do an eye movement therapy over telehealth, there must be a support person present. And by present, I don't necessarily mean in the room. Some of my fellow colleagues require the person to be in the room. However, I find that clients often feel uncomfortable with that, and they may want to be working on issues that they don't want other people in their home or their friends to hear. So the way I manage that is I have the support person, we put a release of information on file, I have their phone number and permission to reach out to them. And that person has to check in at the beginning of the video, and they have to stay present in the building or the house, wherever they are, the whole time, so that I can check in with them. And that means sometimes that I have late cancels because somebody comes on and I say, we're not going to do it without your support person because I'm not going to put you at risk. But that has worked very well for me. There are other clinicians who utilize the support person to actually administer the eye movement. So you would train the support person how to be in the room and administer the bilateral stimulation. However, then you get the issue of, do they feel comfortable with that person? Is that person maybe involved in the content of the images and scenes that they're working on? So, and Laura, I see your comment where the client is not tech savvy. Yeah, and they're on their phone and moving around. Some of those things, comes with the territory and we have to get a little bit used to it, but we can train our clients too. It's a psychoeducation process at the end about how telehealth is the same as what we do in person, but also how it's different and what it takes for them to get the most out of it. So just like we tell clients in person, you get out of therapy what you put into it. Same thing with telehealth. If you come to telehealth distracted and multitasking, you're not going to get as much benefit as if you put your device on do not disturb and you turn off your phone and you make sure that you focus. I have some people who do it on their iPad on purpose because they are really bad about multitasking if they're on their computer and they have a keyboard, right? So choosing the appropriate device that will help them not multitask. Good. So how to gently address. I hope I covered that for you, Laura. You can also suggest that people get a stand, and mine is right here. So this is like something free I got at a conference, right? But if you have a client who is always bobbing around on their device while you're trying to do telehealth, just invite them to maybe get a cheap stand like this that they can set their phone in. My client who does it in her car, I had her put a pop socket thing on her dashboard so that she can put her phone there and not be holding it, because it also interferes with hearing, right? If they're holding the phone where the speakers are and the microphone is. Using earbuds is helpful too to decrease some of that background noise. Yes, not knowing how to use the telehealth, creating instructional videos, and then scheduling a free, 20-minute consultation or 15-minute consultation before their first session just to get their tech working. If you have an office manager or someone that, if you are blessed with that, you can have somebody that works with you, call them ahead of time to work through the tech issues that they might encounter, change any settings, just so that you know that on the day of, and they're ready to start their therapy, that they're going to be equipped. I do the same thing for my students. I teach at a university and we have a mandatory orientation before our live class so that on Monday morning when we're supposed to be in lecture, I'm not getting 20 messages about I can't get Teams to work, right? And that just helps you be proactive. You're still going to encounter some issues, but I find that setting all those things up ahead of time minimizes those. All right. And I gave you just kind of a sample. I don't personally do this, but I have seen people take a picture of their regular office and use it as their virtual background if they're out of town or they're somewhere else. I think if you do that, you do need to tell the client, because I feel like it can be a little bit deceptive, right? I'm trying to trick you into thinking that I'm at home, but I have seen people do that. So just be aware of how that would be perceived to your client. Or you can say, I'm out of town and I'm by myself in the hotel room, but I wanted you to feel like you were right at home, and then pop that up. All right. Oh, sorry, I changed it on my screen and not on your screen, so you didn't see that. But I have seen some people that do that to make people feel safe and comfortable in the space, even if you're not in that space.
Thanks, Jen. Okay, so just to kind of go into a little bit more detail, what Jen was talking about as steps to ensure safety and quality. She had mentioned having that support person or that emergency contact of somebody who is who's aware that the session is happening, and that you will know their current location and how to reach them throughout the entire session. That's a really important component of this. I know we had seen some people mention, what do you do if someone turns their computer off or their trigger? Having that secure contact information for somebody that is there is essential. The release of information for that person, for that support and emergency contact. So that's all paperwork that's done pre-telehealth session. Also ensuring privacy. So you're going to ask your client about their location, what their current location is. Do they have privacy? Do they feel comfortable? And then some of the paperwork, the informed consent and the eye movement informed consent. Those are two examples that we've provided you in the link of all of the handouts. So you'll see the copies of those. And I believe, Jen, we've got some copies of those once we go past this slide. But also the telehealth safety plan. So you want to make sure all of these components are part of that safety plan. And the follow-up. So a day after, you want to follow up for all trauma and eye movement sessions with your clients. You want to follow up with them. Jen and I were discussing this actually before we started today, and she says often she has to follow up with her clients because they forget to follow up with her because they feel great after their sessions. So making sure you follow up with them, and then always to keep in mind that there's other considerations for the client. The instances of domestic violence within the home, if there's kids or other people, other family members in the home, and then the distractions and other devices that may come into play while you're trying to operate this session.
And here's a few of those. You won't, again, it's hard to read them on the PowerPoint. So we've given you these forms in the handout as a PDF, but this is just a sample. You can have these uploaded into your EHR. So the idea is that you have one consent for actually just doing telehealth and then another for the eye movement portion. And I'll give you an example. And having the location of the client and having the emergency person, I've only ever had to use it twice. And both times I had to use it was not a mental health issue. It was a medical issue. I had a student with a kidney stone who got very sick during a live class and said, I think I need to call 911, and went off of video. And I couldn't get a hold of her or her support person, but I had her address and I had to send EMS to her home. And thankfully she passed her kidney stone and she came back to class the next day. I felt terrible for her, but those are the kind of things that can happen. And that's why always knowing the location. When I run a group on telehealth, even if it's a support group, not a therapy group, I require the participants to put in the chat that they're at their home address that's on file with me. And if not, they have to text me their address. So in the chat privately, I don't tell them that they can't go to grandma's house and have their session or come to group or go wherever. But if I cannot tell they're in their home location, then I verify it, because what if they're eating a snack and they get choked on a peanut, right? And I can't get any help to them. So you knock on wood and you hope you never ever need it, but when you need it, you need it. So make it a practice to always know their location, and to have that active release form for the support person.
Jen, someone's asking where are these forms in the chat? We sent a link, and I think it's been sent. It's up in the chat. There's a link to all of them.
And the link was emailed. And Taylor, maybe you could pop it in again for us. What you have is this entire presentation in handouts, and at the end, you've got several research articles and these forms that you could use and edit for yourself or create your own versions.
There it is. Thank you, Taylor.
Yeah. So again, these are just screenshots, and I realize that you can't read them on the PowerPoint, but you do have them. So all the things we've been talking about are what is listed in these forms. So if we're talking about screening for the technology aspect, questions you might ask are, how might the person's computer skills, knowledge, platform, and internet access affect therapy? Is the person motivated and capable of experimenting with new techniques? What are the workarounds? I usually have people have an alternate in case a system is down. We have a plan B. Having your clients also download your platform on their phone and their computer. So if one goes down, they can jump in on the other. And I would recommend doing the same for yourself. If you can be hardwired into your internet instead of relying on bandwidth of Wi-Fi, that's better too. When you are doing telehealth, reminding everybody else in your family not to stream videos and play video games online while you're in session will help you as well. So, and that's a good question. So is the client accessing the internet from a secure location or not? Is part of our job in informed consent to let them know the risks and benefits, just like we would any other treatment. So if you choose to have your session at Starbucks, you need to realize that you're waiving your privilege and confidentiality. I can't ensure that your session is, what you say in your session is private, and helping people think about the implications of that for their own boundaries and mental health. If I'm working with someone who has a history of sexual abuse and never developed healthy boundaries, and then they want to have every session, I don't know, on the playground while their kids are playing and other moms are sitting by them, it might be a therapeutic moment for me to talk with them about how does that relate to the boundaries we've been working on? How does that protect your mental and emotional health? So I think you handle that on a case-by-case basis. And then we've got some screening questions for treatment as well.
So obviously we've got them listed here, but just some of the questions. How might the previous and concurrent mental health treatment affect online therapy? Is the person currently involved in other online in-person mental health treatments, and how will this influence their therapy? How might the person's personality type or their current symptoms and diagnosis influence the person's suitability for online therapy? How might physical and medical factors affect online therapy? So one of the, do they have any medical conditions that might hinder them from being able to utilize eye movements, or medical conditions that can cause them to be distressed while, working through a virtual platform? Is the client able to properly move their eyes back and forth? So this is back to what I was just saying, without aggravating any pre-existing medical condition. And you'll see an example of how this can come into play when I do my practice one, actually, that was not even planned. But certain medical conditions can aggravate those and can trigger people. And then how might cross-cultural issues affect therapy?
All really, really important things to consider.
Yeah.
And I'll give the disclaimer now so I don't forget it later. When we show you the sample session video, I need to ask you to do the same informed consent. If you have a seizure disorder, if you're epileptic, if you have an eye problem that moving your eyes from left to right would cause a medical issue for you, please do not follow the ball when you watch the demonstration video. Oh, that's a good question. Callie asked, how do you work with a client that has a heavy accent? That can be really challenging. I think if you're getting any delay in the video, you just go straight to also having the phone, because you're having to listen harder. Don't stress yourself out by struggling with bad tech. If it's not working, say, hey, let's also do the phone because I want to make sure I don't miss anything. And that might really help you with the client and a heavy accent. Because if you're also dealing with buffering and you're trying to make sure that you understand and get past the language barrier, if you're having to work extra hard just to hear, then it's stressful for both of you. And having really great tech too. It's made a big difference for me when I got a podcast studio quality microphone and an external speaker. So when I'm sitting here in this webinar with you, I am not relying on the mic and speakers that are on my laptop. So I have an external webcam and I have a very nice podcasting mic that I stole from my husband. He gave it to me because I promised him a brand new one. But it makes a very big difference in the quality of the sound, because you can also change those to be unidirectional or omnidirectional. And if you're playing a video, switching it to omnidirectional allows you to get all the sound from the speaker. You're sharing a video with your group or your client, versus if you're speaking directly into it, you want it to be the omnidirectional. And they're not that expensive. This one, which is like an older version, I think was $60. The one I use is called the Blue Snowball, but there are plenty of mics out there. You can buy a little stand that they go on, and even a screen if you feel like you're getting a lot of breath noise into it. So you don't realize how big a difference it makes until you hear it in the opposite. A lot of people are using the ring light as well. I don't have one, but we were actually just talking about they're very inexpensive now. A ring light goes behind your camera and lights this way so that you don't have shadows. But in speaking about eye movement therapy, the lighting is very important, because one of the roles of the therapist is to watch the eyes and make sure that the eyes are doing what they're supposed to be doing. So if my client's face is covered with hair, or if they're sitting at an angle to a window and I've got a shadow where I cannot see that their eyes are moving properly, I need to have them readjust to make sure that I can see them. Yeah. So I'm going to pause right here. I know we're leaving time for questions at the end, but we're about to move into talking about using specific trauma modalities in telehealth. So anybody have questions about general telehealth right now that we haven't covered? Okay. And it may come up later. I just wanted to give the opportunity. So nothing new, there's nothing new under the sun, right? Every treatment that we have has evolved from the treatment before it, which evolved from the theory before that. So if we want to do a 2-second version overview of trauma history, we started talk therapy for trauma because we know that people need to vent. It's cathartic, right? And like Kelly said earlier, it changes our view of ourselves and the world, and we have to change it back or come up with a new way of seeing the world as a result of our trauma. So, but what we find is that that's very hard. People have a lot of physical sensations. They dissociate, they dysregulate as they're doing that. And that doesn't always, the talking doesn't always provide the desensitization component. So along comes prolonged exposure that says it's really hard, but let's put people in a simulator that has them re-experience getting blown up in a combat situation, right? No wonder people drop out of that. I mean, could you imagine doing that every week for 14 weeks? But the people who are able to successfully complete it report that they are desensitized to some of those stimuli. But a lot of people who drop out report re-traumatization in the process. So then along comes Francine Shapiro in EMDR, and she says, well, we have to do the exposure to get the relief, but what if we pair it with a relaxation response? What if we can keep the body regulated while we're working on the trauma, and then it won't be as re-traumatizing? And so hence we have EMDR and other eye movement therapies. And then Kelly and I in particular are trained in accelerated resolution therapy, which takes that a step further and is a very directive protocol that helps people keep their traumatic images more contained and also addresses the body sensations all the way throughout the process. So you're never looking at more than 45 seconds of your trauma scene without checking and regulating your body. Never, ever. And then ART also includes a component of memory reconsolidation and rescripting. So this might blow your mind. It blew my mind when I first learned it, but Dr. Kevin Kipp, in one of the very first trainings I was in with him, he said, PTSD is not an anxiety problem, it's a memory storage problem. And that was like mind-blown paradigm shift, because all of the distress is associated with the images. If I can stop those vivid images from replaying, I can remember the story of what happened to me without experiencing significant distress in my body. It doesn't erase my memory. I don't implant a false memory. It's not hypnosis. I'm totally awake. But when my brain restores that memory, it creates new proteins and voluntarily attaches a new image that is not distressing. So this science of memory reconsolidation is included in some of the newer trauma therapies like RTM, reconsolidation of traumatic memories, and accelerated resolution therapy. So we credit everything that has come before us when we learn a new technique, and we're thankful that we're further along now than we were 20 years ago in helping people heal. Because I believe the statistic is 24 million Americans live with PTSD, and it's not just combat veterans. Right. So interaction time.
Jen, real quick, somebody wanted you to repeat Dr. Kipp's quote about PTSD.
Yeah, what he talked about was that PTSD has always been categorized as an anxiety disorder, and it is because it causes panic and extreme anxiety, but scientifically, it's really a memory storage problem. If you think of your brain like a computer, when your computer goes to sleep at night, it is defragmenting. It's processing and consolidating information to make it run faster. But the reason we have nightmares is because those images will not process and be put away and stored properly. That's why they flash back, and we have them in nightmares and flashbacks while we're awake. So if we can help the brain finish that process, then this traumatic memory is no longer an annoying pop-up that comes up intrusively, right? So PTSD is a memory storage problem.
Thanks, Jen. Okay, so we're going to do another poll just to kind of see where everybody's at. We want to know what treatment modalities you are already using or you're currently using in a telehealth delivery, and you can choose multiple. I think you can choose multiple ones, right? Okay, yeah, thanks.
Yes, you can.
Thank you.
And then there's also the second component
Yep.
of that poll as well.
Yep,
And
there's another question below, and how are they working for you?
While y'all are filling that out, I'd like to let you know that we are putting together another link. The one that I sent y'all just had the PowerPoint. We're putting together another one that's going to have everything in it, and we will put that in the chat, and we'll be emailing it to you after the webinar as well. So don't worry about that.
Thank you.
Give y'all some time to put the polls in.
It's like a lot of trauma-focused CBT.
Looks like some people had in. I keep losing it. All right. Okay, we got most people have submitted, so I'm going to share the results. Yeah, it looks like trauma focused cognitive behavioral therapy. Ooh, that's a mouthful.
Jen, look at how, when I asked you about the equine, nobody's using, which is funny because I was not aware that people are actually using equine assisted psychotherapy through a telehealth platform.
That was an interesting discussion we had. I didn't think it was possible either. But in the EGALA method, 2 of the types of activities we do are relate and observe. And clients who were in traditional equine therapy and then had to stop it during shutdowns were missing the horses. So these therapists and equine specialists got together and figured out how to do observe and relate activities on video. So the therapist and the equine specialist would go and be with the horses, but the client would be on video, and it kept them connected. Obviously, that is not the ideal way to do equine therapy, because there is such a hands-on experiential component of being in the horse arena. But when we're talking about trauma-informed care, right? How creative was that? To keep those clients engaged in their session and stay connected to them, even if all we did was go and visit with our teammates, the horses, while we couldn't be together, right? Because that would just be one more connection lost during the pandemic. So I thought it was brilliant. So what we're noticing in our poll is that the large majority, like I'm a social worker, I don't do math in my head, but upwards of 90% of us are using a talk-based trauma therapy. And in a minute, I'll show a slide about how breaking them down into categories, and we'll talk about when you're using a talk-based trauma therapy, what else you should pair with it to help address the body piece. Kelly, anything else that you want to?
No, that was it for the polls. I mean, I did see somebody mention something real quick, that someone uses DNMS, which is Developmental Needs Meeting Strategy, which is attachment-based EMDR, IFS type therapy. I want to make sure that we're notating some of the people that their selections weren't listed on there.
I saw motivational interviewing as well.
Yep.
And I have heard wonderful things about internal family systems. I am not personally trained in it, but hearing really good things about it as well. So speaking of those different types of therapies, if 90+% of us are using talk-based, those are things like CPT, trauma-focused CBT, narrative exposure therapy, trust-based relational intervention, TBRI, IFS, so many acronyms, right? And it's not, please don't ever hear me say that a trauma therapy is wrong or bad, because not everything works for everybody. So your client needs what works for them. But what I am saying is, if you're using a talk-based trauma therapy, I would really encourage you to have the client pair it with some type of physical activity that helps the body release the stored trauma. So that could be that they plan extra time to go for a run after they do a trauma-focused CBT session, or they go to massage, they do craniosacral massage, or they go to a yoga class, preferably directly after their trauma therapy session if possible. Because one of the downsides of talk-based trauma therapy is that it works the trauma out of the mind, but not out of the body. And that's why people say, I did 14 weeks of CPT, and in my head, I know it's okay for me to go to the grocery store, but as soon as somebody gets too close from me, I freak out, right? I'm triggered. I have a flashback. I can't stay. I have to leave the grocery store. And that's because the body remembers. We've probably all read The Body Keeps the Score. And the talk-based therapies don't necessarily have a component for helping the brain and the body work out those physical sensations. So there's a lot of creative ways you can do that. Tai Chi, karate, kickboxing, just pairing it with a physical activity that brings the relaxation and calmness to regulation to the nervous system. And then we have other experiential therapies. We mentioned equine. Creative arts therapy has some really powerful components of imagery. Neurofeedback and biofeedback, which are kind of in a different, real brain techie science type techniques, but trauma changes the way our brain waves function. So using neurofeedback in conjunction with talk therapy, or having people do a course of neurofeedback to help their brain get realigned. We have 5 primary types of brain waves. Delta for sleep, and there's more than 5, but they fall into these categories. So delta for sleep, theta is like dreamy right before you fall asleep. When you're doing yoga, sometimes you get into a theta state. Alpha is our calm but awake state, and then beta and gamma are our high function brainwaves. So when I have PTSD and I'm not getting enough sleep, I don't have enough delta, I have way too much beta gamma going on because I'm having intrusive thoughts and ruminating and my brain is going, right? And so I'm not making enough of the brain waves that calm and regulate the nervous system. This is why people develop substance use disorder. When you have a drink of alcohol, your brain temporarily produces alpha waves. That's why you feel relaxed, but it wears off. But in neurofeedback, we can help people's brains restore alpha waves and their relaxation waves to a healthy balance. Yeah, definitely emotional freedom technique is a way to regulate the nervous system as well. That's a great example. So doing some of those experiential therapies for people who just don't want to talk or who aren't responding to traditional talk therapy. We already mentioned the 2 major eye movement-based therapies in play right now, EMDR and ART. And then we've got exposure-based therapies like prolonged exposure, traumatic incident reduction, rapid resolution therapy, and reconsolidation of traumatic memories. As far as I know, RTM is the only one in that list that's also using the component of memory consolidation the way that ART does. So, I think the takeaway from this, 2 takeaways. One is, if I'm using a talk-based therapy, what can I pair it with to help my client get better results? You can also institute grounding and nervous system calming at the beginning and the end of your talk therapy session to help them stay regulated. And if I'm only trained in a talk-based therapy, maybe my next CEU training should be one where I fall into a different category so that I have alternatives for my clients who have serious trauma. Anything you want to add?
What were you saying?
You want to add to that before you?
No, I just think that's a perfect segue into talking about accelerated resolution therapy, which is something that you and I both feel very strongly about. We do a lot of our work is surrounded around the use of accelerated resolution therapy. So we're going to show a video of Dr. Diego Hernandez, who is one of our lead national trainers. He's a very esteemed colleague who has been involved in quite a bit of research surrounding ART. I know he's done some work with the Mayo Clinic and the University of South Florida, and working with research surrounding post-traumatic stress, grief. What are some of the other ones? I'm just blanking on him, but I know he's done quite a bit.
A small study on application of ART in chronic pain.
Yes.
Several military studies, grief,
complicated grief. Yes.
Complicated grief. And also, I believe, a small study with cancer.
Yes, that was with the Mayo Clinic.
Yeah.
Yep. So we'll show you guys a video of Diego where he gives a brief description, 3-minute description of ART.
And what I want to challenge you to do is listen as he's talking, see if you can identify the 5 primary elements of trauma therapy as he describes ART. See if you hear them all in there.
Accelerated resolution therapy is an emerging psychotherapy and therapeutic system that takes some of the best elements of existing therapies like Gestalt, EMDR, and a variety of other approaches, and it targets unresolved emotions and experiences. These unresolved emotions and experiences or memories are actually stored differently in the brain. Information gets processed throughout the day, and at night it gets sorted out and it goes to the cerebral cortex, the top part, the more advanced part of the brain, for long-term storage. These experiences stay below that. They're subcortical. They're kind of free floating. The sensations, the smells, the all the aspects of that are related to survival actually are held on to. In fact, when you go through a situation where that system is engaged, where it's the fight, flight, or freeze response that we talk about, the body responds in such a way so that way you can recall as much information as necessary. So there's about 5 other different approaches right now that are all trying to target that process. In the past, most of my experience has been learning different techniques and approaches to help people live with the experience, get used to the experience, and to be able to tolerate it, and to calm themselves down. I was very involved initially with trauma-focused yoga, meditation, things that really emphasize the body and how the body responded. And you can actually see the bridge from that work towards accelerated resolution therapy, as well as some of the other approaches through the work of Bessel van der Kolk, who actually looks at what happens in the body when somebody experiences a traumatic experience. So art targets that, which is very different than some of the other approaches, in a very condensed way, where let's say prolonged exposure, you might go 10 to 15 sessions and explore the same event. And art, it's designed for a 60 to 90-minute session to actually go through that single event in a single session, and it's driven towards resolution. That's why it's accelerated resolution, because you want to resolve that event. Over time, working with somebody, and continue to resolve events, as a result, you see the reduction in symptoms. So we're not targeting the symptoms, like psychiatry would, or other therapies. We are targeting the event.
All right. I know we're getting close to the end of we just got a notification about Q&A, Jen. So I want to just real quick, we do want to show you guys the video, how the current application of ART is being utilized and performed through a telehealth setting. So we're going to show an example of a session that Jen and I had last week. And do you want to go ahead and play, or do you want me to talk about what happened first or after?
Tell them after. I think
Okay.
let's build the suspense. Again, my disclaimer, if you have epilepsy or would not be cleared to do eye movements, please don't follow the ball. And this is not a whole session, it's just an introduction to how you would manage the technology and actually administer eye movements online.
Kelly, thank you so much for coming today. How are you doing?
Good. How are you?
Doing well. And I know we plan to do ART today. So Ava, thank you so much for being here and checking in. We've already got our safety plan on file and a release form for Ava. So Ava, I have your number. And if we need anything through the session, I will give you a call.
Perfect. Thank you.
Thank you so much.
Okay, thank you.
You're welcome.
So I know we already picked out a theme that we were going to do with ART, but let's just check in. Is that still what you want to work on today, or is there something else that has come up since then?
Well, I had a really bad migraine yesterday, and it's something that hasn't happened in quite some time, and I think it's all kind of stress, caused by some stress that I'm experiencing in my life right now. So I don't know if we're able to work on that.
Okay. Do you have some sensations left over from having that headache yesterday?
I still have like a dull pain, kind of in my temple area and my forehead it just feels like my brain is sore from yesterday.
Okay. Yeah, well, let's work on that first. We're going to make sure that we have all our technology working for us and that we choose the right speed for you. So just like we talked about, you're going to keep your head still facing the computer, and you'll only be moving your eyes. And I'll let you know if we're focusing on body sensations or if we're focusing on another image. When you're on your body sensations, if your brain tries to go somewhere else, just bring it back to your body and try to stay really focused on the sensation. So let's check our speed first. All right. So let's follow the ball and see if this speed is too fast or too slow.
That's going to be too fast.
Okay.
Sorry.
No problem. We will switch it. Okay, let's try this speed and see how this is for you.
That's much better.
Much better. Okay, well, we will go with the medium speed here. So all we're going to do for this first set as we get used to using the software and tracking with your eyes is we're going to notice that dull ache that's left over from your headache yesterday. Okay, so just notice that, and you could even imagine draining it out or dialing it down. Okay, here we go. And deep breath. And check that sensation. Did it change or move?
It definitely, I think I was anxious about using my eyes like that after what happened yesterday, but definitely towards the second half of it was a lot easier for me to do.
Okay. Yeah, and where did you feel that anxiety in your body about just trying to use your eyes and not wanting to trigger a headache?
Yeah, I felt it in my chest, but I kept trying to focus on my brain and just calming it and feeling like a cooling sensation.
Okay. Well, let's take that cooling sensation that was helping and just spread it all over your body. And it can also cool and wash out that tension that you felt in your chest. So we'll do one more set on that. Cool it all down. Here we go. And deep breath. Were you able to spread that cooling sensation?
Yeah, I feel much more calm.
All right. And that's as far as we're going to go right now. So I'm going to go ahead and stop our video. Kelly, thank you so much. Kelly, thank you.
All right. Well, and I just, wanted to let everyone know that I did have a great deal of relief following that brief session with the eye movements of the pain that I was carrying around in my head. I'm a firm believer in the body holds the score, and I had a rough day before that, and was very thankful that I was very nervous about even doing eye movements. So I was very thankful that Jen was able to lead me through just those two brief little sessions, and definitely helped me continue my day and be able to get the work done I needed to get done. So I think now we want to move on to Q&A, Jen.
Yes, we want to give you some time. So you kind of saw a snippet, a sample of what that would be like. I did see the question about the moving ball. There are a lot of ways to administer that. There are some free EMDR softwares. Accelerated Resolution Therapy endorses one called Insight Innovations that you can purchase an annual subscription. I have these videos. I actually had them made for me, and they are specific to the ART protocol, but they are available on my website for a download. I can put the link if anybody wants it. I had somebody make them because talking about telehealth, when you are streaming the motion, whatever you're using, a ball or a square that moves across to track. When you're streaming it from a server and you're screen sharing it, you've got double the chance for delay. And if your ball is jerky, that is very distracting to the process. The client can't follow. So that's one of the reasons I had these made, so that I am not dependent on a software to run that. It's just a video on my hard drive, and then I share it with the client. And if they're having tech issues, I actually send it to them and have them download it on their machine, and they start and stop it if they can't get it to not buffer when I'm sharing it. So that's my plan B. Have a plan B for everything, all the tech issues. And Taylor, you're going to facilitate our Q&A, right? So
Let's start. We got some questions from towards the beginning that are focused more on telehealth. So let's see. Someone said, I've got one young client who often turns off the camera and mutes herself when she gets triggered, and it's challenging to coax her to get back on. Seems like that's
I think in those situations, and I don't know, I don't see a lot of teams on telehealth. I have in the past, and I always require that a parent be home, and then I could reach the parent. And for me, that would be a safety and a boundary issue. You don't have to talk, but you have to leave your camera on. If you don't want my assistants to calm back down, that's okay. I can give you a few minutes, but I have to know that you're safe. So for me, I would involve the parent, and the client would need to at least leave their camera on, even if they needed a break. I don't know if anybody else has a thought on that.
So Callie McKenzie asks how to work best with clients that are continually re-hospitalized via telehealth.
Yeah, so our high acuity clients are the ones we worry about the most. And we, potentially having additional check-ins with them, definitely collaboration with their other service providers, knowing where their inpatient place is that they go and building a relationship there. I think you have to foster that a lot more on telehealth because you're not right there where you can go for a meeting and an interdisciplinary staffing, but working really on a lot of coping skills too, to have them, which is something we all do already. I wish I had a magic answer for you on how to help our really difficult clients, but we have the same struggle in person with our severe and persistent mental illness and our really challenging high acuity clients.
So another question based on trauma resources. So what resources would you recommend to get training on non-traditional talk-based therapies, such as exposure-based therapies?
Well, I might be able to hit two questions with one stone here. Somebody else asked about training in ART online. So currently we do not offer the basic ART training online. And that's because it involves watching full sessions of the protocol, and the client's consented for that to be used for training, but not to end up on YouTube. So we have no guarantee in a setting like this that someone wouldn't screen record those session videos. So we have not determined an alternate way to give the basic training online at this time, but we are offering them socially distanced with limited numbers, and you get a packet with hand sanitizer and a mask and everything when you get there. And so I have been extremely quarantined, and ART trainings are like the only thing I really go out for. And I have probably done 6 or 8 since things have opened back up safely. I'm gonna knock on some wood, but we're being very conscientious of that. But right now, there's just really no way for us to deliver that. And Kelly, you may have a comment about that.
No, I would just, agree with what you said. We're doing everything we can to make sure people are safe. We're providing tons and tons of trainings throughout the United States. But we're keeping the groups very, very small, you know, and allowing people, if they do have any fears of attending, then we're just allowing them to move to a different training until they're comfortable. But definitely it's just been it's hard to, this is a modality that would be difficult also, I think, to fully teach online. It's a very experiential training that's 3 days long. So right now, just being done in person.
So, curious about the biggest difference between ART and EMDR.
Kelly,
Did
wanna
you
go?
give that handout? Did you give them that handout? Okay, so there's a wonderful handout that was included in the link of handouts that was written by Dr. Charles Hogue, and it's a really great contrast and comparison of ART and EMDR. Dr. Hogue was the lead clinical director, or lead director of Walter Reed Hospital. So he's a firm believer in trauma-based therapies, and he did an excellent job. I would say that the biggest, probably the most common comparison that we find, and Jennifer had touched on it earlier, is that ART utilizes a lot of the components of EMDR with the eye movements, but it's much more targeted. It's much more directed. ART focuses on one experience, image, or memory at a time and moves you through that entire process. Where sometimes with EMDR, if somebody has experienced multiple traumas or complex trauma, when they're going through the eye movements, they can be flooded with images and memories, and it can become very difficult to focus on one at a time. So the ART providers, the clinicians, are trained to really keep you on track, to move you through that entire and process out that one experience, and then to work on the additional ones in later sessions.
I think, yeah, those are the primary, the focus on body sensations. More, the analogy I use is, imagine if your brain was a house and you walked into your brain and you opened up all the closet doors and let everything fall out. That would feel very overwhelming. And in ART, what we're saying is walk into the house, but keep all the doors closed except for this one, and only walk to this one and open it and let whatever falls out, and we'll deal with that. So it's that containment piece and the reconsolidation, the way we change the memory, the way it's restored.
Okay. So it looks like that's all. Oh, looks, we got one more question in the chat. Any apps that you would recommend for clients between sessions? My computer. So any apps that you would recommend for clients between session care related to relaxation and or deep breathing?
I have a gigantic list that I'm glad to share to anybody that would want to email me. I have it broken down by like chronic pain, goal setting, anxiety, depression. But specifically for PTSD, the DoD has put out a free app called PTSD Coach. And it's extremely helpful, and it's free. You don't have to be a veteran or a service member to use it. There's also CBTI, which is an app for cognitive behavioral therapy for insomnia, and plenty of other ones, but I am glad to send my list to anybody who wants it.
All right, well, it looks like that was the last of the questions in our chat, and we've hit our time. I just want to hand it back over to y'all. If y'all want to have anything else you want to say.
Taylor, what is the best procedure? Like, if everybody wants the list, can you get me email addresses, or do they need to email me directly and I can do it individually?
If you'd like to put your email in the chat, that way whoever like the list, they can email you. We will be sending y'all a follow-up email that will contain that link with all of the documents. I also want to let y'all know that we'll be holding a 40-hour board approved supervision training. It's going to be via webinar June 9th to 11th. You can register on our website now at naswtx.org, and we'll also be releasing a 3-hour advanced supervision video course later this month. So please check our homepage or call our chapter office for more information.
And the last thing that I have is don't forget to use humor for self-care. So, I mean, social workers doesn't take to change a light bulb. Fun, but the light bulb has to want to change. Thank you guys so much. It's been a privilege spending the afternoon with you.
Thank you.